Hey students, today we are going to read chapter number 4, Axilla, from the book B.D. Chaurasia, Human Anatomy, Volume 1. And this is your Nandini ma'am. So let's get started. Introduction. The axilla, Latin armpit, is a pyramidal space situated between the upper part of the arm and the chest wall. It resembles a four-sided pyramid and has the following: an apex, a base, four walls: anterior, posterior, medial, and lateral. The axilla is disposed obliquely in such a way that the apex is directed upwards and medially towards the root of the neck, and the base is directed downwards. Figures 4.1a and b. Dissection. Place a rectangular wooden block under the neck and shoulder region of cadaver, figure 4.1. Ensure that the block supports the body firmly. Abduct the limb at right angles to the trunk and strap the wrist firmly on block projecting towards your side. In continuation with earlier dissection, reflect the lower skin flap till the posterior axillary fold made up by the subscapularis, teres major, and latissimus dorsi muscles is seen. Clean the fat and remove the lymph nodes and superficial veins to reach depth of the armpit. Identify two muscles arising from the tip of the coracoid process of scapula. Out of these, the short head of biceps brachii muscle lies on the lateral side and the coracobrachialis on the medial side. The pectoral muscles with the clavipectoral fascia form anterior boundary of the region. Look for upper three intercostal muscles and serratus anterior muscle which make the medial wall of axilla. Clean and identify the axillary vessels. Trace the course of the branches of the axillary artery. Reflect the upper skin flap on the arm till the incision already given at its junction of upper 1/3 and lower 2/3. Boundaries. Apex, cervicoaxillary canal. It is directed upwards and medially towards the root of the neck. It is truncated, not pointed, and corresponds to a triangular interval bounded anteriorly by the posterior surface of clavicle, posteriorly by the superior border of the scapula and medial aspect of coracoid process. Medially, it is bounded by the outer border of the first rib. This oblique passage is called the cervicoaxillary canal. The axillary artery, axillary vein, and the brachial plexus enter the axilla through this canal. Base or floor. It is directed downwards and is formed by skin, superficial and axillary fascia. It is convex upwards in congruence with concavity of axilla. Anterior wall. It is formed by the following: the pectoralis major in front, figure 4.3, the clavipectoral fascia, pectoralis minor. Posterior wall. It is formed by the following: subscapularis above, figure 4.4, teres major, and latissimus dorsi below. Medial wall. It is convex laterally and formed by the following: upper four ribs with their intercostal muscles, upper part of the serratus anterior muscles, figure 4.5. Lateral wall. It is very narrow because the anterior and posterior walls converge on it. It is formed by the following: upper part of the shaft of the humerus in the region of the bicipital groove, and coracobrachialis and short head of the biceps brachii, figure 4.5. Contents of axilla. Axillary artery and its branches, figures 4.6 and 4.7. Axillary vein and its tributaries. Infraclavicular part of the brachial plexus. 5 groups of axillary lymph nodes and the associated lymphatics. The long thoracic and intercostobrachial nerves. Axillary fat and areolar tissue in which the other contents are embedded. Layout. Number 1. Axillary artery and the brachial plexus of nerves run from the apex to the base along the lateral wall of the axilla, nearer the anterior wall than the posterior wall. Number 2. The thoracic branches of the axillary artery lie in contact with the pectoral muscles, the lateral thoracic vessels running along the lower border of the pectoralis minor. Figure 4.10a. Number 3. A part. The subscapular vessels run along the lower border of the subscapularis. B part. The subscapular nerves and the thoracodorsal nerve to latissimus dorsi, cross the anterior surface of the subscapularis, figure 4.4. C. The circumflex scapular vessels wind around the lateral border of the scapula, see figure 6.12. D. The axillary nerve and the posterior circumflex humeral vessels pass backwards close to the surgical neck of the humerus. 4. A part. The medial wall of the axillary is avascular, except for a few small branches from the superior thoracic artery. B. The long thoracic nerve to the serratus anterior, descends on the surface of the muscle. Figure 4.5. C. The intercostobrachial nerve passes the anterior superior surface or part of the medial wall and crosses the spaces to reach the medial side of the arm. See figure 3.3. Number 5. The axillary lymph nodes are 20 to 30 in number and are arranged in 5 sets. A. The anterior group lies along the lower border of the pectoralis minor on the lateral thoracic vessels. B. The posterior group lies along the lower margin of the posterior wall along the subscapular vessels. C. The lateral group lies posterior medial to the axillary vein, figure 4.11. D. The central group lies in the fat of the axilla. Number E. The apical group lies behind and above the pectoralis minor, medial to the axillary vein. Clinical anatomy. The axilla has abundant axillary hair. Infection of the hair follicles and sebaceous glands gives rise to boils, which are common in this area. Axillary artery. Axillary artery is the continuation of the subclavian artery. It extends from the outer border of the first rib to the lower border of the teres major muscle, where it continues as the brachial artery. Its direction varies with the position of the arm. The pectoralis minor muscle crosses the artery and divides it into 3 parts. Figure 4.6. First part, superior or proximal to the muscle. Second part, posterior or deep to the muscle. Third part, inferior or distal to the muscle. Relations of axillary artery. Relations of first part, anterior. Skin, superficial fascia, platysma, and supraclavicular nerves. Deep fascia, clavicular part of the pectoralis major, figure 4.7a. Clavipectoral fascia with cephalic vein, lateral pectoral nerve, and thoracoacromial artery. Loop of communication between the lateral and medial pectoral nerves. Posterior. First intercostal space with the external intercostal muscle. First and second digitations of the serratus anterior with the nerve to serratus anterior. Medial cord of brachial plexus with its medial pectoral branch. Lateral and posterior cords of the brachial plexus. Medial, axillary vein, the first part of the axillary artery, is enclosed together with the brachial plexus in the axillary sheath derived from the prevertebral layer of deep cervical fascia. Relations of second part, anterior. Skin, superficial fascia, deep fascia, pectoralis major, pectoralis minor. Figure 4.7b. Posterior. Posterior cord of brachial plexus, subscapularis. Lateral cord of brachial plexus, coracobrachialis, figure 4.8. Medial. medial cord of brachial plexus, medial pectoral nerve, axillary vein. Relations of third part, anterior, skin, superficial fascia, deep fascia. In the upper part, there are the pectoralis major and the medial root of the median nerve, figure 4.7c. Posterior, the radial nerve, figure 4.9. Axillary nerve in the upper part, subscapularis in the upper part, tendons of the latissimus dorsi and the teres major in the lower part, figure 4.7d. Lateral, coracobrachialis, musculocutaneous nerve in the upper part, figure 4.8, lateral root of median nerve in the upper part, trunk of median nerve in the lower part, medial, axillary vein, medial cutaneous nerve of the forearm and ulnar nerve between the axillary artery and the axillary vein, medial cutaneous nerve of arm, medial to the axillary vein, figure 4.9. Branches. The axillary artery gives 6 branches. 1 branch arises from the first part, 2 branches from the second part, and 3 branches from the third part. These are as follows, figure 4.10. Superior thoracic artery. Superior thoracic artery is a very small branch which arises from the first part of the axillary artery near the subclavius. It runs downwards, forwards, and medially, passes between the 2 pectoral muscles, and ends by supplying these muscles and the thoracic wall, figure 4.10. Thoracoacromial or acromiothoracic artery. Thoracoacromial artery is a branch from the second part of the axillary artery. It emerges at the upper border of the pectoralis minor, pierces the clavipectoral fascia, and soon divides into the following 4 terminal branches. A. The pectoral branch passes between the pectoral muscles and supplies these muscles as well as the breast. B. The deltoid branch runs in the deltopectoral groove along with the cephalic vein. C. The acromial branch crosses the coracoid process and ends by joining the anastomosis over the acromion process. D. The clavicular branch runs superior medially deep to the pectoralis major and supplies the acromioclavicular joint and subclavius. Lateral thoracic artery. Lateral thoracic artery is a branch of the second part of the axillary artery. It emerges at and runs along the lower border of the pectoralis minor in close relation with the anterior group of axillary lymph nodes. In females, the artery is large and gives off the lateral mammary branches to the breast. Subscapular artery. Subscapular artery is the largest branch of the axillary artery arising from its third part. It runs along the lower border of the subscapularis to terminate near the inferior angle of the scapula. It supplies the latissimus dorsi and the serratus anterior. It gives off a large branch, the circumflex scapular artery, which is larger than the continuation of the main artery. This branch passes through the upper triangular intermuscular space, winds around the lateral border of the scapula between 2 slips of the teres minor, and gives a branch to the subscapular fossa and another branch to the infraspinous fossa, both of which take part in the anastomosis around the scapula. See figure 6.12. Anterior circumflex humeral artery. Anterior circumflex humeral artery is a small branch arising from the third part of the axillary artery at the lower border of the subscapularis. It passes laterally in front of the intertubercular sulcus of the humerus and anastomosis with the posterior circumflex humeral artery to form an arterial circle around the surgical neck of the humerus. It gives off an ascending branch which runs in the intertubercular sulcus and supplies the head of the humerus and shoulder joint. Figure 4.10b. Posterior circumflex humeral artery. Posterior circumflex humeral artery is much larger than the anterior artery. It arises from the third part of the axillary artery at the lower border of the subscapularis. It runs backwards, accompanied by the axillary nerve, passes through the quadrangular intermuscular space, and ends by anastomosing with the anterior circumflex humeral artery around the surgical neck of the humerus. See figures 6.6 and 6.12. It supplies the shoulder joint, the deltoid, and the muscles bounding the quadrangular space. It gives off a descending branch which anastomoses with the ascending branch of the profunda brachii artery. Anastomosis and collateral circulation. The branches of the axillary artery anastomose with one another and with branches derived from neighboring arteries. Internal thoracic, intercostal, suprascapular, deep branches of transverse cervical, profunda brachii. When the axillary artery is blocked, a collateral circulation is established through the anastomosis around the scapula, which links the first part of the subclavian artery with the third part of the axillary artery, apart from communications with the posterior intercostal arteries. See figure 6.12. Clinical anatomy. Axillary arterial pulsations can be felt against the lower part of the lateral wall of the axilla. In order to check bleeding from the distal part of the limb in injuries, operations, and amputations, the artery can be effectively compressed against the humerus in the lower part of the lateral wall of the axilla. Axillary vein. The axillary vein is the continuation of the basilic vein. The axillary vein is joined by the venae commitants of the brachial artery, a little above the lower border of the teres major. It lies on the medial side of the axillary artery, figure 4.9. At the outer border of the first rib, it becomes the subclavian vein. It receives 5 out of 6 tributaries corresponding to the branches of axillary artery and the cephalic vein. Veins accompanying branches of thoracoacromial artery drain directly into the cephalic vein. Lateral thoracic vein of upper limb is joined to superficial epigastric vein of lower limb by thoracoepigastric vein, enabling blood to return to heart in blockage of inferior vena cava. See flowcharts 14.1 and 14.2. Axillary lymph nodes. The axillary lymph nodes are scattered in the fibrofatty tissue of the axilla. They are divided into 5 groups. Number 1. The nodes of the anterior or pectoral group lie along the lateral thoracic vessels, that is, along the lower border of the pectoralis minor. They receive lymph from the upper half of the anterior wall of the trunk and from the major part of the breast, figure 4.11. Number 2. The nodes of the posterior or scapular group lie along the subscapular vessels on the posterior fold of the axilla. They receive lymph from the posterior wall of the upper half of the trunk and from the axillary tail of the breast. Number 3. The nodes of the lateral group lie along the upper part of the humerus, medial to the axillary vein. They receive lymph from the upper limb. Number 4. The nodes of the central group lie in the fat of the upper axilla. They receive lymph from the preceding groups and drain into the apical group. They receive some direct vessels from the floor of the axilla. The intercostobrachial nerve is closely related to them. Number 5. The nodes of the apical or infraclavicular group lie deep to the clavipectoral fascia along the axillary vessels. They receive lymph from the central group, from the upper part of the breast, and from the thumb and its web. The lymphatics from the thumb accompany the cephalic vein. Anterior and central groups of nodes are often involved in carcinoma breast. Clinical anatomy. The axillary lymph nodes drain lymph not only from the upper limb but also from the breast and the anterior and posterior body walls above the level of the umbilicus. Therefore, infections or malignant growths in any part of their territory of drainage gives rise to involvement of the axillary lymph nodes. Bimanual examination of these lymph nodes is therefore important in clinical practice. Left axillary nodes to be palpated by right hand and right axillary lymph nodes have to be palpated by left hand. An axillary abscess should be incised through the floor of the axilla, midway between the anterior and posterior axillary folds and nearer to the medial wall in order to avoid injury to the main vessels running along the anterior, posterior, and lateral walls. Spinal nerve. Each spinal nerve is formed by union of dorsal root and ventral root. Dorsal root is sensory and is characterized by the presence of spinal or dorsal root ganglion and enters the dorsal horn and posterior funiculus of spinal cord. Ventral root is motor, arises from anterior horn cells of spinal cord. Figure 4.13. The motor and sensory fibers get united in the spinal nerve, which divides into short dorsal ramus and long ventral ramus. Both the rami thus contain motor and sensory fibers. In addition, these also manage to obtain sympathetic fibers via gray ramus communicants. Only the ventral primary rami form plexus. Brachial plexus is formed by ventral primary rami of C5 to C8 and T1 segments of spinal cord. Brachial plexus. The plexus consists of roots, trunks, divisions, cords, and branches. Figure 4.14. Roots. These are constituted by the anterior primary rami of spinal nerve C5 to C8 and T1 with occasional contributions from the anterior primary rami of C4 and T2. Figure 4.8. The origin of the plexus may shift by one segment either upward or downward, resulting in a prefixed or postfixed plexus respectively. In a prefixed plexus, the contribution by C4 is large and C5 is present, T1 is small, and from T2 is often absent. In a postfixed plexus, the contribution by T1 is large, T2 is always present, C4 is absent, and C5 is reduced in size. The roots join to form trunks as follows. Roots and trunks, supraclavicular part. Roots C5 and C6 join to form the upper trunk. Roots C7 form the middle trunk. Roots C8 and T1 join to form the lower trunk. These lie in the neck between the scalenus anterior and scalenus medius muscles carrying axillary sheath from prevertebral fascia. See figure 12.10. Divisions of the trunks. Retroclavicular part. Each trunk, 3 in number, divides into ventral and dorsal divisions, which ultimately supply the anterior and posterior aspects of the limb. These divisions join to form cords. Cords and branches, infraclavicular part. Number 1. The lateral cord is formed by the union of ventral divisions of the upper and middle trunks, 2 divisions. Number 2. The medial cord is formed by the ventral division of the lower trunk, 1 division. Number 3. The posterior cord is formed by union of the dorsal divisions of all the 3 trunks or 3 divisions. These are named according to relation of cords to the second part of axillary artery. Sympathetic innervation. Number 1. Sympathetic nerves for the upper limb are derived from spinal segments T2 to T6. Most of the vasoconstrictor fibers supplying the arteries emerge from the segments T2 and T3. Number 2. The preganglionic fibers arise from the lateral horn cells and emerge from the spinal cord through ventral nerve roots. Number 3. Passing through white rami communicants, they reach the sympathetic chain. Number 4. They ascend within the chain and end in the middle cervical, inferior cervical, and first thoracic ganglia. Number 5. Postganglionic fibers from middle cervical ganglion pass through gray rami communicants to reach C5 and C6 nerve roots. Postganglionic fibers from inferior cervical ganglion pass through gray rami communicants to reach C7 and C8 nerve roots. Number 7. Postganglionic nerves fibers from first thoracic sympathetic ganglion pass through gray rami communicants to reach T1 nerve roots. Number 8. The arteries of skeletal muscles are dilated by sympathetic activity. For the skin, however, these nerves are vasomotor, pseudomotor, and pilomotor. Vasomotor constricts the arterioles of skin. Pseudomotor increases the sweat secretion. Pilomotor contracts the erector pylorem muscle to cause erection of the hair. Branches. The roots value of each branch is given in brackets. Branches of the roots. The roots value of each branch is given in brackets. Number 1, nerve to serratus anterior, long thoracic nerve, C5 to C7. It only supplies serratus anterior muscle, one of the key muscles for overhead abduction. Number 2, nerve to rhomboids, dorsal scapular nerve, C5. This nerve supplies rhomboid minor and rhomboid major muscles responsible for retraction of the shoulder girdle, giving rise to levator scapulae. Number 3, branches to longus colli and scalene muscles C5 to C8 and branch to phrenic nerve C4. The root of phrenic nerve from C5 is small 1. The main root is from C4. Phrenic nerve is the sole motor nerve supply of thoraco-abdominal diaphragm. In addition, it carries afferent fibers from mediastinal pleura, fibrous pericardium, and part of the parietal peritoneum. Branches of the trunks. These arise only from the upper trunk, which gives 2 branches. Number 1, suprascapular, C5, C6. This nerve supplies supraspinatus and infraspinatus muscles. Number 2, nerve to subclavius, C5, C6. It supplies the small subclavius muscles. It may give a root for phrenic nerve. Branches of the cords. Branches of lateral cord. Number 1, lateral pectoral, C5 to C7. This nerve supplies both pectoralis major and pectoralis minor muscles. Number 2, musculocutaneous, C5 to C7. This is the nerve of muscles of front of arm, that is coracobrachialis, both the long and short heads of biceps brachii and the brachialis muscles. Number 3, lateral root of median, C5 to C7. It joins the medial root of median nerve. Median nerve is the chief nerve of the muscles in front of forearm and of muscles of thinner eminence. Branches of medial cord. Number 1, medial pectoral, C8T1. It also supplies both the pectoralis minor and pectoralis major muscles. Number 2, medial cutaneous nerve of arm, C8T1, carries sensory impulses from a small area of medial side of arm. Medial cutaneous nerve of forearm carries sensory impulses from large area of medial side of the forearm. Ulnar, C7, C8, T1. C7 fibers reach by a communicating branch from lateral root of median nerve. This is the nerve of 1.5 muscles of front of forearm and 15 intrinsic muscles of the palm. Number 5, medial root of median, C8, T1. It joins the lateral root and gets distributed with branches of median nerve. Branches of posterior cord. Number 1, upper subscapular, C5, C6. This nerve supplies large multipinnate subscapularis muscles. Number 2, nerve to latissimus dorsi, C6 to C8. Only supplies muscles of its name. It is also called thoracodorsal nerve. Number 3, lower subscapular, C5, C6. It helps upper subscapular nerve in supplying of the subscapularis muscles. In addition, it supplies the teres major muscle. Number 4, axillary circumflex, C5, C6. It is responsible for supplying one of the most important muscles of a shoulder, the deltoid. It also supplies small teres minor muscle. Number 5, radial, C5 to C8, T1. This is the thickest branch of brachial plexus. It supplies all the 3 heads of the triceps brachii muscle. Then it supplies 12 muscles on the back of forearm. In addition to the branches of the brachial plexus, the upper limb is also supplied near the trunk by the supraclavicular branches of the cervical plexus and by the intercostobrachial branch of the second intercostal nerve. Sympathetic nerves are distributed through the brachial plexus. The arrangement of the various nerves in the axilla was studied with the relations of the axillary artery. Special features: the lateral cord, the medial cord, and their branches form the letter M with the three corners extended. Figure 4.8 inset. Lateral cord gives musculocutaneous and lateral root of median, blood supply of brachial plexus. Vertebral artery and thyrocervical trunk with its branches, the suprascapular and transverse cervical arteries supply blood to the brachial plexus. These are the lifeline of this important plexus. Dissection. After cleaning, the branches of the axillary artery proceed to clean the brachial plexus. It is formed by the ventral primary rami of the lower four cervicals, C5 to C8, and the first thoracic nerves. The first and second parts of the axillary artery are related to the cords, and third part is related to the branches of the plexus. Study the description of the brachial plexus before proceeding further. Clinical anatomy. Global total brachial plexus birth, baby, is the most severe type of paralysis. Erb's paralysis. Site of injury. One region of the upper trunk of the brachial plexus is called Erb's point, figure 4.15. Six nerves meet here. Injury to the upper trunk causes Erb's paralysis. Causes of injury: undue separation of the head from the shoulder, which is commonly encountered in the following: birth injury or difficult childbirth, fall on the shoulder, during anesthesia. Nerve roots involved, mainly C5 and partly C6. Muscles paralyzed, mainly biceps brachii, deltoid, brachialis, and brachioradialis. Partly supraspinatus, intraspinatus, and supinator. Deformity and position of the limb. Arm hangs by the side, it is adducted and medially rotated. Forearm extended and pronated. The deformity is known as policeman's tip hand or waiter's tip hand or potter's tip hand, figure 4.16. Disability. The following movements are lost: abduction and lateral rotation of the arm at shoulder point, flexion or supination of the forearm, biceps and supinator jerks are lost, sensations are lost over a small area over the lower part of the deltoid. Klumpke's paralysis, site of injury, lower trunk of the brachialis plexus. Cause of injury: undue abduction of the arm, as in clutching something with the hands after a fall from a height or sometimes in birth injury. Nerve roots involved, mainly T1 and partly C8. Muscles paralyzed: intrinsic muscles of the hand, T1, and ulnar flexors of the wrist and fingers, C8. Deformity and position of the hand: claw hand due to the unopposed action of the long flexors and extensors of the fingers. In a claw hand, there is hyperextension at the metacarpophalangeal joints and flexion at the interphalangeal joints. Disability: complete claw hand, figure 4.17. Cutaneous anesthesia and analgesia in a narrow zone along the ulnar border of the forearm and hand. Horner syndrome. If T1 is injured proximal to white ramus communicans to first thoracic sympathetic ganglion, there is ptosis, meiosis, anhidrosis, and enophthalmos, and loss of ciliospinal reflex may be associated. This is because of the injury of sympathetic fibers to the head and neck that leave the spinal cord through the nerve T1, figure 4.18. Vasomotor changes. The skin area with sensory loss is warmer due to arterial dilatation. It is also drier due to the absence of sweating as there is loss of sympathetic activity. Trophic changes. Long-standing case of paralysis leads to dry and scaly skin. The nails crack easily with atrophy of the pulp of fingers. Injury to the nerve of serratus anterior, nerve of belly. Causes: sudden pressure on the shoulder from above, carrying heavy loads on the shoulder. Deformity: winging of the scapula, that is excessive prominence of the medial border of the scapula. Normally, the pull of the muscle keeps the medial border against the thoracic wall. Disability: loss of pushing and punching actions. During attempts at pushing, there occurs winging of the scapula. See figure 2.12. Overhead abduction of the shoulder girdle is partly affected due to intact trapezius muscles. Right. Facts to remember. Sternoaponeurotic part of pectoralis major twists around the upper fibers of the same muscle. Latissimus dorsi twists around the teres major. Thus, the smooth anterior and posterior walls of the axilla are formed. Infraclavicular part of brachial plexus lies in the axilla. Apex of the axilla is also known as cervicoaxillary canal and gives passage to axillary vessels and lower part of brachial plexus. Axillary sheath is derived from prevertebral fascia. Clinico-anatomical problem. A patient came with inability to abduct right shoulder, flex elbow joint, and supinate the forearm. What is the site of injury of the nerves? What is the joint point called? And what are the nerves affected? The site of injury is the Erb's point. 6 nerves are involved. Ventral ramus of cervical 5 segment of spinal cord. Ventral ramus of cervical 6 segment of spinal cord. These two rami join to form the upper trunk. Suprascapular nerve from upper trunk. Nerve to subclavius from upper trunk. Anterior division of upper trunk. Posterior division of upper trunk. These divisions give fibers to deltoid, brachialis, biceps brachii, supinator, and so the arm cannot be abducted. The elbow is extended and forearm is pronated. This paralysis is called Erb's paralysis. So this was our chapter Axilla. So see you soon with the next chapter.